Okay. Whoops, okay, these are my disclosures. Okay, what I want to discuss with you today is how azacitidine is possibly given to the ideal patient, or better, just identify together with you which are the subgroups of patients who are responding and responding differently. So I do not need to introduce to you the molecule azacitidine and the analog, the cytabine. These are two cytosine analogs that have been used already for some years, so I suppose that you are very much familiar with it. What I want to recall you is the fact that azacitidine and the cytabine are both actively intaken by the cells and then activated by several enzymes, UCK and then azacitidine, which goes 80% into RNA, by ribonucleotide reductase goes into DNA as well. So there is an active uptake and activation of the two molecules before they are uptaken by DNA. I will never succeed. And what we call DNA methyltransferase inhibitors are in fact active as hypomethylating drugs. It's not just the name that we're giving them. Azacitidine decreases the level of methylation. You see here, if you take in vivo, ex vivo, and you treat in vivo, and then you check at week 0, week 1, and week 4, you see that in black you have heavy methylation, which goes down immediately after treatment and then tends to grow up again while the time passes by. And not only this, but the hypomethylating effect of azacitidine is different in different cellular models, meaning that there is an intrinsic possibility of the cells and thus of patients to respond differently to this drug. I told you I will learn at the end. We learned in this year many things. We learned that this kind of drug, and azacitidine in particular, doesn't work immediately. We have to wait at least 4 cycles to judge whether a patient is responding. We can achieve only hematological improvement and be happy with it. We don't look for CR. We do not want to interrupt the therapy because these cause loss of response. And of course, patients with complex karyotype may respond, but their response is very short. And I will touch upon all these problems in my talk. And patient-resistant or relapse have an extremely short survival. Now, azacitidine is inducing a response. You see, is inducing hematological response and CR and PR. It's not incredibly active in this sense. So if you show this to an AML colleague, he would say, okay, it doesn't work because the amount of CR plus PR is really limited. And actually, what is more interesting is that this drug is prolonging overall survival, and you know that. So the approval in Europe of azacitidine is based on the fact that it prolongs significantly overall survival in respect to other treatment. So even if the percentage of patients achieving CR and PR is not enormous, you do have an important prolongation of survival. Oh, I'm so sorry. So what about the response? All over, you see, you have a 51% of response, judged as CR, 33%, PR, or hematological improvement. And the great majority of these patients have achieved such a response within 6 months, not immediately. So this is another dogma we have to sort of forget for MDS. Is not the quicker the better. Sometimes you have slow responding patients who are doing very well. Some of them responding even after 1 year. And when you see some response, you do not have to stop because you lose response, but also because you may improve the quality of such a response. This is, it has been shown to you already. This is showing that you have indeed 2 years survival, median overall survival for the patients receiving azacitidine. And then, this is more important, if you compare a patient who has achieved CR after azacitidine to a patient who has achieved CR after low-dose RSC or high-dose chemo or, well, not with best supportive care, you see that even so, even if the type of response is the same, the patients receiving azacitidine are living longer. And the most surprising fact is this one, that the patient who achieve hematological improvement with azacitidine are experiencing a significantly longer survival than the one achieving hematological improvement with other treatment. And this is the novelty of this treatment. So we may really induce only hematological improvement. And this is very important just to compare with other treatment. This is the question and the doubt we all have. If I have a patient who's stable after 3 months of treatment, what do I have to do? Do I have to go on? Do I have to stop? Is a resistant patient? So we checked and we picked up all the data from 001, and we saw that the patients who were stable at 3 months, at 6 months, so if we prolong of 3 months still therapy, had a 20% improvement in their response. So they achieved a hematological improvement, whereas with other therapy, you still can, but for a lower percentage of case. And this is the most important question. I told you that you judge response at 6 months. What happens if you do not have a response at 6 months and you have a stable disease? And you go on for 3 months, and here, this is a small percentage, but still a percentage of patients who are improving despite the fact that they respond slowly. So why is this response so slow? Is only because of the fact that this drug has to hypomethylate? So can we find a way to define what is important here and whether we will finally achieve response? Is there an ideal patient for azacitidine, and can we exclude a patient from the beginning from this treatment? In other words, are there factors predictive of response? Now, if we look at cytogenetics, the only parameter in higher risk MDS, you see that, of course, patients with normal karyotype respond very well as patients with non-complex karyotype, including trisomy 8, or deletion 5q, as it has been already told you, but the worst patients are these ones with complex karyotype and monosomy 5 or 7. These are the patients we are not able to let survive longer. These are the patients who do not take much advantage of the drug and on which we have to work to improve the outcome. But still, I would not renounce to treat a patient with this drug. And of course, you already saw this slide, was shown to you by Dr. Hades. And this is the result of the French study. You see that if you treat a patient who already received low-dose RSC, you are bound to be unsuccessful. And normal karyotype, whereas normal karyotype and low number of blasts are okay, the response duration depends mostly on the karyotype. So complex karyotype may respond, but for a very short time, and this is just talking about response. If you consider the overall survival, then you have different parameters. Performance status, and you already heard about comorbidities, circulating blast, transfusion, and of course karyotype once again, which is quite important. But there are now clinical and molecular parameters which are pretty important. Now, if you have a patient who's doubling platelets very quickly, this is a very positive parameter for judging response. Whereas, as I told you, these from the beginning, and the marrow fibrosis grade 3 is accompanied by a scarce response to azacitidine. Mutated TET2 was already alluded to, is a prognostic parameter for good response, whereas P53 complex karyotype, once again, low expression of UCK1, I'll come back to this, and mutated XL1, there are different publications on this subject. Just recently, TET2 mutation, if you have a variant allele frequency of more than 10% in your patients, in terms of TET mutation, you will have a higher probability to respond to azacitidine. But if together with TET2 mutation you have ASXL1 wild type, your probability increases, whereas if TET2 is accompanied by ASXL1 mutation, you lower the probability to respond. And this has been already shown to you as well. It's a tentative score to analyze some clinical parameter like platelets, white blood cells, but also TET2 and here the MT3 mutations as positive parameters for response. And here you have the cytogenetics, once again, ASXL1, and you see hemoglobin, age, and SF3B1. So a mixture. This is the work of the group of Cleveland, Fabiola Traina, and they try to set up a score to establish whether, once again, you may have a response or an overall survival. And you see, once again, that these are distinct studies and parameters. Well, we tried for many years to establish a link between methylation and response to azacitidine, but unfortunately, there was never such a strong data supporting it. So it doesn't mean that it doesn't work via hypomethylation, but we were not looking at the right thing. We were looking at promoters, and this is just what we did for AZA001. We compare patient with CDNK2B methylated. You see that they will respond better to azacitidine than to CCR. But once again, this was not enough to respond to treatment. And this was done with cadherin, another gene promoter. Then there was an interesting study in which was shown that patients who decreased methylation of the promoter of phosphatidylnositol phospholipase C beta 1 were prompt to respond, whereas this is shown in, during treatment with decitabine. Patients who achieved CR and PR had also a decrease in methylation, global methylation. So this was interesting, but was not enough to say this patient will respond or not. So if we come back, I just want to recall you that we need some active molecules to intake the two molecules, the two azacitidine and decitabine, and then you need to activate the azacitidine in particular to obtain hypomethylation. So we studied, with my group, gathered 57 cases of MDS, treated in vivo with azacitidine at the standard dose, and we checked gene expression profile, methylation assay, and sequencing, and we showed that the patient who responded had higher level of UCK, and they were also responding for a longer time, and their overall survival was much better. So this is how they had expression, but this was not regulated by aberrant methylation. There were no polymorphism that we could detect. So we are busy now trying to understand how we regulate UCK1. And here you see that if you silence UCK1 in vitro in cells, you see that you abolish the effect of azacitidine. So you take a small interfering RNA against UCK1, and you expose the cells to azacitidine, and in black you should have the number of cells apoptotic after treatment, and you see that you do not have any effect, whereas this is the control not treated with anti-I. And then age. Very, very often I hear colleagues who are telling me, okay, but this patient is 76, 75, so I don't treat him or her. Now, of course, age is a risk factor, but we shouldn't base our choice on age. We should have another hour to speak about frailty and comorbidities. what was clear is that the patient above 75 would respond very well to azacitidine, even better than the general population age 70. And this is the French study in which they considered patient older than 80, and you see again that their overall survival is overlapping after treatment. And then, is azacitidine active only in high-risk MDS? Lou Silverman showed very many years ago that this was not IPSS, but these were patients with, let's say, refractory anemia who would respond quite well in terms also of prolongation of overall survival to azacitidine. Of course, in Europe, azacitidine is not approved for low-risk MDS, but we had a small study in Italy showing that patients with low-risk MDS and pre-treated, still transfusion-dependent, could still respond quite well, and the safety was good, so that if you see all the studies published, you may affirm that lower-risk MDS patients may do respond to azacitidine as well. Now, these studies are performed with sub-Q azacitidine, whereas now you may know that there is an oral azacitidine study for lower-risk MDS, transfusion-dependent, and thrombocytopenic. And of course, overall survival was also prolonged by this treatment, as well as transfusion independence was achieved by this treatment in all patients. This is the American study, one of the first, and you see that around 60% of patients respond. Last but not least, what about the patients who are WHO AML? That is with 20–30% of marroblast. Do they respond? Well, these are all the patients that we extracted from the AZA-001, and you see that these patients with higher number of blasts still respond with 50% survival at 2 years. And if you take the worst patients, the ones that you would not treat with intensive chemo because they are unfit, still they have a significant advantage from treatment with azacitidine. So we should not exclude patients that we judge unfit and leukemia from treatment. And you see in leukemia as well as in MDS, you may achieve CR much more efficiently with intensive chemo, but the prolongation of survival is achieved with azacitidine, even if you get only hematological improvement. I told you in the beginning that the patients who are not responding to azacitidine or who are losing response to azacitidine are unfortunately have a very bad survival time and a very bad outcome, only few months, 5 to 6 months, despite the fact that you may apply other salvage therapy. Now, which kind of therapy can we use? We don't have much. We have investigational agents and we have transplant. If the patients we are treating have become eligible for transplant in the meanwhile, intensive chemo or low-dose RC are not really increasing their survival, so are not to be recommended for use after azacitidine failure. And you see that best supportive care is also not bringing any advantage in terms of survival. So the two, investigational and allogeneic, are the best. And you see there is no significant difference, but it seems that if you may perform a transplant would be the best option. And this is my group, and thanks for your patience and for listening.